Okay, we're going to try and start on time, just so that we have lots of time for our speakers and for for questions.
Can you hear us okay?
Thank you all for coming. This is a symposium called Social and Environmental Impacts on CF Health Outcomes. My name is Michael Schechter. I'm a professor of pediatrics and pediatric pulmonologist at the Children's Hospital of Richmond at Virginia Commonwealth University.
And I am Dana Albon. I'm an associate professor at the University of Virginia in Charlottesville. We are very close by.
So we're neighbors, yeah. So just to give you a little bit of an overview of what this symposium, is all about. Basically, it's well known that social determinants of health influence outcomes for people with CF, and this symposium aims to describe mechanisms of health disparities in CF. I'm sorry. This symposium aims to describe mechanisms of health disparities in CF with particular attention to socioeconomic, environmental, and geographic location influences. And an international international perspective will be emphasized. So our educational objectives are to analyze environmental and socioeconomic factors, interactions, and influences on CF health outcomes. Number two, to describe the impact of rural residents on access and outcomes in CF care. And number three, discuss the challenges of CF care in low and middle income countries. So to kick things off, our first speaker is Stephen Colgate. Stephen is a postdoctoral research fellow at Cincinnati Children's Hospital Medical Center. His research work focuses on improving the case crossover designs for cystic fibrosis studies and advocating group-level fairness and machine learning precision tools in clinically based settings. If you want to know more about it, you can read his bio on your phone. But otherwise, I think I'm going to just leave it at that. So, Stephen, take it away.
Thank you so much. Good morning, everybody. Thank you for attending the session here today. I'm going to be talking about some of the work that I've been involved with at Cincinnati Children's, me and my colleagues that we've been working with, collaborating, working on advancing CF care with related to personalized and environmental influences on CF-related outcomes here. Okay, so there we go. Yeah, I do not have any relationships to disclose related to the presentation here. So built environmental adversity has been linked to earlier, more rapid decline in both pediatric and adult patients with cystic fibrosis. These personalized and environmental exposures help us to identify early indicators of rapid lung function decline. And the interactive computational medicine tools that we have built help us to dynamically predict rapid pulmonary decline in CF and enhance local disease monitoring. This allows clinicians to monitor, forecast a patient's lung function in real time and incorporates various different treatments such as HEMT initiation. We also looked at daily fluctuations in environmental exposures and how they affect acute lung function exposure. So patients' risk of lung function decline could fluctuate day by day depending on various different environmental exposures. And so we implemented several novel functional data and joint model approaches in partnership with the CF Foundation using their national patient registry. These social determinants of health that we looked at, these two primary categories are the neighborhood and the built environment. When you walk outside, things that negatively affect lung function exposure, things like traffic-related air pollution, acute PM2.5 exposure, land use, how much green space is available within the neighborhood that you live and work in, seasonality and temperature, really getting into the weather impact of environmental exposures, and then housing. How well does the patient have a good living conditions inside of their home? We also took a look at social and community contexts, including community deprivation index and crime and how that impacts CF-related healthcare. And so the work that I'm going to be showing here is a compilation of various different projects that we're doing at Cincinnati Children's that leverages these characteristics to precisely identify those individuals who are at greatest risk for rapid lung function decline. So at Children's here, we put together a novel stochastic model with personalized thresholds of determining lung function decline here. This paper was published by my mentor, Dr. Rhonda Shuzniak at Cincinnati Children's. And this model here has been deployed into a corresponding app that includes a gradient of rapid decline thresholds that uses enhanced real-time prediction via cystic fibrosis point personalized detection for medical monitoring, and also includes several different add-ons from the Cystic Fibrosis Foundation's Learning Network's data-driven definition of rapid decline events, such as the FEV1 indicated exacerbation signal, or FIAS here. So you can go to this website right now on your mobile device or computer here and check out this corresponding app for yourself. Just go to predictfev1.com and click on the CFPOPD link here. And when you load up the app here, you have several different options that you can choose from. You could take a look at several different subsetting options, depending on one of 43 different patients, depending on what cohort year they're in, depending on sex, birth cohort, some other different characteristics that you can select, and you can plot their FEV1% predicted right there on the app, including their actual measured FEV1% predicted and their trajectories, both actual observed and predicted values there. And you can use this tool to identify the risk of rapid decline and make that forecast here. That's down there in the lower panel there. And you can adjust the risk probability there. That's what's highlighted there in that orange box in the corner of that panel. And you can also take a look at some other characteristics related to the patient over time, such as the number of pulmonary exacerbation events, the number of clinical visits per year, and some other relative useful information about that patient there. This corresponding app has incorporated a change point for estimating the jump in the FEV1 trajectory after they start HEMT initiation here. So for example, you could see pre-initiation, you can see their lung function there, but as soon as the lung function decline here happens, they begin the treatment of HEMT, and you can see this jump in FEV1 trajectory here. The corresponding app that we have developed here fits this model to longitudinal FEV1 data from these HEMT treated patients, including these previously identified geographic and clinical covariates here. So just to illustrate this improvement here, this dynamic change point model here for two different patients, one male and one female, and on the left correspondent here, you can see their observed FEV1 against the time. That's the gray dots that are presented here. And then you could see the HEMT right after the initiation point here, the improvement of their FEV1 trajectory. And you can also see that incorporated here on the right side of the panels there, their risk of rapid lung function decline, including their predictive probabilities for FIAS, including actual observed FIAS events, which are indicated by the red X's here. This model, we evaluated it based on five-fold cross-validation. So the first row uses the training cohort. The second one uses masking, where the last 2 years of their data were masked in their forecasts. And then the third row was independent holdout sub-cohort for testing purposes here. And so looking across this table, both for FEV1 trajectories and for FIAS, this model has excellent individualized prediction of rapid decline and overall accuracy FEV1 trajectories and FIAS events. We took a look at several different environmental exposures that help us identify rapid lung function decline. So a colleague of mine who was, if you attended my talk in the session yesterday, you would have seen Imra. He gave a nice presentation about a Bayesian model here. He, at Cincinnati Children's and our cohort, we developed phenotypic signatures of environmental adversity and rapid FEV1 decline. during adolescence and early adulthood. And this allows us to develop and deploy a novel environmental adversity index that takes into considerations geomarkers at the zip code tabulation area or the ZICTA level, including things like air pollution, green space, crime, and area level deprivation, which then gets summarized into a composite score to cluster longitudinal FEV1 values there. And then we took a look at how these environmental adversities play out through plotting it geographically to show pockets throughout the United States where we could see where rapid lung function decline could be most imminent. This work was already previously given at a previous conference here. So I'll go ahead and move this a little bit quickly through here. We took a look at several different environmental predictors, such as geographic. This includes things like ambient air pollution, PM 2.5 values, traffic-related air pollution. We also looked at climatology, weather-related events, and then we also included neighborhood characteristics such as proximity to the roadway, distance to the nearest airport, railroad, bodies of water, things like that. We also looked at community characteristics such as the deprivation index, percent of people with vacant housing, percent of people on assisted income, percent with those who only have a high school education. Social characteristics, kind of going back to that diagram that I showed at the beginning of this talk here. And then we also looked at some predictors that are healthcare related, such as the distance to the CF care center there. So this is a map of the geographic subpopulations that are vulnerable to rapid lung function decline. The phenotypic patterns vary geographically here. So the bluer the colors that you see here indicates more severe peak decline, whereas the darker colors indicate more adverse environmental exposures here. And so we saw that land cover with the highest percent tree canopy coverage, forest areas, rural areas, including lower roadway density and length, correspond to a decreased probability of being an early rapid decliner. And when we looked at the dynamic prediction model for environmental stressors that affect rapid FEV1 decline, we saw that community deprivation, the percentage of green space that's within neighborhoods, the tree canopy cover, and ozone levels all had varying geographic impact on the rate of rapid lung function decline. We took a look at more hyper-localized variables here, such as traffic-related air pollution and deprivation predictors. This was recently published by all of our colleagues here at Cincinnati Children's, taking a look at hyper-localized environmental exposures here, such as traffic-related air pollution, neighborhood-level material deprivation, nearby land use type, and sources related to traffic-related air pollution. Turned out they were highly predictive. We found through this work here that children were more adversely impacted by those within the community in the form of community-level deprivation, but adults are more adversely impacted by individual-level deprivation. So to give you an idea of this hyperlocalization here, this is a map of Hamilton County where Cincinnati Children's resides here. All the data that's presented here is from the Cincinnati Children's CF Center cohort covering Hamilton County, Ohio, which has a mix of both rural areas but also urbanized areas and suburban areas here. And you can see basically on the map the FEV1 decline, the percent predicted per year, and you can really see where the urban centers are. If you take a look at this map here, you can see where the interstate highways are. You can kind of make out where the interstates are, which are located here. And you can also see where more of the rural and suburban areas here, where you don't really see that much traffic-related air pollution that's present. When we aggregate it to the ZICTA level here, you notice that a lot of that granularity goes away because you're having to take into account the size of the zip code here of work done previously. We looked at daily changes in air pollution and see how does that affect the risk of a pulmonary exacerbation event through a case crossover design here. So we identified pulmonary exacerbation cases based on rapid lung function decline using the FIA's definition for a pulmonary exacerbation event. The idea here is that we have a large cohort of cystic fibrosis patients, and they were all given electronic home monitoring devices to monitor their FEV1 at home. They were asked to measure their FEV1 values at least 2 times a week there. And so we put together a model that incorporates this decline in their rapid lung function decline. And then if we notice that the decline is severe and it meets that FIAS definition for a pulmonary exacerbation event, we would classify that as a case here. So we took a look at all the pulmonary exacerbation cases that meet the FIAS definition for a pulmonary exacerbation event, and we matched them to 3 or 4 control dates within the same year, that same month, and the same day of the week here. We looked at also lag days up to 3 days prior to the pulmonary exacerbation case onset in order to really make sure that we capture that air pollution exposure prior to their pulmonary exacerbation onset. We then, once we identified the case dates and then control dates that we compare it to, we then use a prediction algorithm to get a machine learning algorithm that incorporates 41 different predictors to calculate 24-hour average background PM2.5 estimates that it's weighted at the residential zip code. And then we implemented our design using a conditional logistic regression model that's stratified by person case to obtain an overall odds ratio of the incidence rate. And then we also take into account several covariates that are associated with PM2.5 background estimates, including temperature, relative humidity, and day of the year to accommodate that here. So we had 121 participants aged 14 to 69 years from the patient registry, observing about 7,000 lung function measurements from October 2011 to July 2015. And by using a 14-day washout period, we identified 1,432 pulmonary exacerbation event cases that correspond to roughly 4,800 control dates here. And so the odds ratio of daily PM2.5 exposure, we found that to be significantly associated with an increased risk for a pulmonary exacerbation 1, 2, and 3 days prior to the onset of pulmonary exacerbation exposure. So what we conclude from this work here is that if PM2.5 measurements or exposure spikes, say like fireworks or smoke, or not having a lot of rain in the last couple of days, if those background levels of PM2.5 suddenly spike, we saw an increase in pulmonary exacerbation cases up to 3 days after that acute increase in PM2.5 exposure. So concluding our remarks here, based on the summary of the work that we've done here, these are just a sampling of some of the projects that we got going on at Cincinnati Children's. We've been using statistical science, data-driven projects here, using computational methods and statistical models to predict rapid pulmonary decline. We accomplished acute, accurate, dynamic prediction models to personalize individual environmental health interventions before and after HEMT initiation. We collected and implemented novel and established geomarkers of environmental adversity and precisely defined novel phenotypes of rapid decline. And we monitored daily changes in air pollution exposure and how that affects a person with cystic fibrosis and their risk of experiencing a FIAS-defined pulmonary exacerbation event at the very hyper local level. These metrics that we have built and has allowed us to improve forecasting of rapid lung function decline beyond just the regular routine clinical characteristics and effectively classify environmental lung phenotypes and determining a rapid decline effects that are caused by sudden acute environmental changes there. So that's just some of the work that we've been doing at Cincinnati Children's. Thank you all so much for listening, and I'm looking forward to your questions and your comments. Thank you.
Question.
There, Sonia Stanovich from Halifax in Nova Scotia. This is really great work, and congratulations to you and the team for kind of giving us insight into this unmeasurable built environment. I'm just wondering, in terms of a practical sense, what proportion of lung function decline or exacerbation risk can be attributed to these environmental exposures? Is it like 50%, 5%? Do you have any idea of that kind of, in like a multi-level context, how much is attributed to these environmental factors?
Ooh, that's a good question. Yeah, so I don't really know that off the top of my head here, but that is something that I will definitely be looking into and seeing, like, now that we have the ability to look at these hyper-localized things here, we could see what percentage of um, things like pulmonary exacerbation events that we can now capture that we couldn't capture before using only clinical events there.
Hi, John Kogan from Seattle Children's. I'm in absolute awe of all of that stuff. I'm just curious if you're able to look for other factors associated with climate change, so specifically like heat exposure for people and how that relates to lung function or other clinical outcomes, and also microbiology and how that may be changing with respect to some of the models. And then do you have data outside of Ohio, or do you have the ability to do that in other locations? So I guess lots of questions.
Yeah. So to answer your second question, yeah, we do have the ability to take a look at environmental exposures outside of the Ohio area there. The example that I gave here was for Hamilton County, which includes Cincinnati Children's data here, but we do have the ability to look outside of the Ohio region area and look at it at a national level there. As far as climate change is concerned, that would be a very interesting direction to go for future work, and seeing how does things like temperature, wind speed, things like that affect cystic fibrosis care. We've done a little bit of that work with the case crossover design, taking a look at temperature, relative humidity, things like that. But I think that would be a great launching point to go and look and see how does weather impact cystic fibrosis related care.
Gabriella Oates, UAB. Talking about your Ohio data, I'm really curious why you decided to up-aggregate to ZICTAs when you do have your residential addresses, because you really lost all the granularity along the way. And we know that social and environmental exposures are not recommended to be assessed on such large geographic unit levels. So what was the rationale behind that?
That's a great comment. The idea behind the aggregation of the ZICTA levels is show how much granularity that you lose if you just aggregate it by the zip code tabulation area, because you're really wanting to look at, the environmental exposures of that person and their surrounding areas, but you may not be necessarily interested in that zip code tabulation area, that entire area there. So we wanted to kind of illustrate what was possible through our work if you looked at it from a hyper-localized level versus looking at just the ZICTA level that is kind of like the standard that it is now, just to compare, just see how that, how you lose a lot of that granularity versus looking at it from a hyper-localized level, like traffic-related air pollution, for example, versus, kind of a more broad area there.
I have a question. I think this is a little bit unfair for you, but so how would you translate this data into clinical practice? Do you see kind of a role of maybe predicting higher risk, and what mitigation strategies could you introduce in clinic to prevent these exacerbations? Kind of tricky question. I don't think there is an answer, actually.
I've been thinking about that as I've been working as a postdoc fellow at Cincinnati Children's. The question that I always get asked all the time when I'm doing some projects like this is, how do you take what we do, using all these models, fancy models, all the data that you collect, building all these maps and fancy plots here. But the question that I always get asked all the time is, how do you take all the information that you learn, that you know, and translate that to the clinicians to help them better account for the care for their cystic fibrosis related patients? And I think that is something that we can do more work on and really show the clinicians like this is how we have the ability to do this, but to really make that connection from going from the research work here to implementing it in cystic fibrosis related care, I think that's potential for a great breakthrough.
So just to follow up on that, so that the website that you referred us to at the beginning is not one that we could plug in individual patient characteristics and get a prediction of what they're going to do. So that might be an initial step to make this more clinically relevant, although then the next question would be, what are you going to do about it when you understand that somebody's at higher risk? Because many of the things that you're mentioning are a little bit more challenging to intervene on.
Yeah.
One other, as long as nobody else has any questions, I was at your talk a couple of days ago at, where you talked a little bit about the issues around race differences and the predictive value of this model. And it might be worth your mentioning that or discussing that here.
Okay, cool. Yeah, I'll give you kind of like a 2-minute like synopsis of what the talk that I gave yesterday. So we looked at the first, let me see if I can go back. So going back to this personalized predicted model here of predicting rapid lung function decline, I took a look at it through the use of how well does this precision learning algorithm predicting rapid lung function decline impact various different groups here. So we took the probability of a rapid lung function decline for 3 different prediction horizons, 3 months, 6 months, and 1 year forward from when a person comes in and get evaluated for a pulmonary exacerbation event, say. And we looked at how well this model accurately predicts pulmonary exacerbations based on those who self-identified as either white, black, and those of another race, and ethnic groups, Hispanics, non-Hispanics, and those who did not report their self-ethnicity. And what we found was, and this was really, really interesting, the model actually has worse prediction accuracy for those who self-identified as black versus those of either white patients or those of another race. And I thought that was a little bit concerning because you would think, okay, the model is formulated, we're treating everybody the same, so 2 people that have the same similar characteristics, they would have the same, prediction accuracy for a pulmonary exacerbation event. And that turns out that those who self-identified as black, they had worse prediction accuracies. And we thought, oh, so how in the world is this racial bias coming in to things like that? And this kind of opens the door for larger questions that a lot of researchers may not necessarily pay attention to is, when we formulate these models, all we're really concerned about is how well does this model predict for this particular individual. We don't necessarily take into consideration things like minority populations, like, black patients, for example, which before our work there, we had no idea that the prediction accuracies were worse for black patients. So we're actively looking for ways to try to mitigate that racial bias that we're seeing in this precision medicine algorithm, based on looking at things as well. Is that racial bias is because of the data that's being collected by these healthcare centers? Is it because of the model? Maybe there's something that's not being accounted for inside the model, or do we calibrate the model results to ensure that all racial and ethnic groups are having the same precision prediction accuracies there?
Great, thanks. And one of the more obvious places where that could be fixed would be the use of race-neutral versus race-based pulmonary function tests, but undoubtedly it's more complicated than that.
Yes.
So that was excellent and wonderful. And I actually was going to ask one more question about where you get your PM 2.5 data for, because historically, at least in our city, Dallas, the regulatory monitors are not necessarily in those areas. And so those those models can be a little bit inaccurate, I believe, because they are so aggregated to areas that have been actually historically redlined.
Exactly.
So do you know any of that information, like where you got your PM 2.5 data from? Were they from EPA regulatory?
So the PM 2.5 data that we used here is from a machine learning model that one of my advisors, Dr. Cole Brokamp, he put together. It uses 41 various different predictors, such as tree canopy usage, amount of water land, all aggregated into a precision medicine algorithm that you put in your zip code, where the person lives inside that zip code there, and then it gets a 24-hour background average of PM 2.5 on that particular day. But one drawback of using that is, is how I use that slide about the ZICTAs there, is that, the accuracy of those PM 2.5, because we only have the zip code level area for those patients, not their addresses. One of the problems that we get is that we can only do as good as the zip code, which, depending on where this person lives, if you live in the rural areas, for example, the zip code could be huge. So those PM 2.5 background levels may not accurately represent what that person's actual exposure is surrounding them. Great question.
Thanks.
Yes, we're going to move on to the next speaker. Thank you so much.
Fantastic. Thank you.
Yeah, Stephen, that was amazing. Our next speaker is Dr. Brown. Dr. Brown is a board-certified pediatrician specializing in cystic fibrosis and was the co-founder of the St. Luke Cystic Fibrosis Center in Idaho.
Good. All right. Thank you all so much for joining me today. It's really a privilege to share some of this information with you. I will tell you, Stephen's talk was great, and the work they're doing is amazing. The talk I'm about to give has way less math, way less statistics, and no machine learning. So this is going to be a very, very different talk. I have no disclosures related to this talk. And just to run through objectives real quickly, the first objective really is going to be to appreciate some of the challenging dynamics and the challenges of rural residents for CF patients themselves. A second will be to understand the difficulties for a CF center and for us CF providers to provide that distant care to CF patients when they live far away. And the third is to explore evidence about whether there are differential outcomes or evidence around access for those who live far away or live in rural locations. So before I go on, how do we define rural? It's a really interesting definition, and it has nothing to do, if you look at the U.S. Housing and Urban Development definition for rural, it has nothing to do with how far away you are from an urban center or a CF center, certainly. The definition is living in a community with a metro area of less than 50,000 people. So technically, pretty much every one of our centers has rural patients. But I promise you, as you'll see in these next few slides, that rural is really different in the West than it really is in New York State, for example. So this is a map of CF centers across the country. And it's really interesting how you can draw a boundary for the eastern half of the U.S. if you go down the western boundary of Minnesota, Iowa, Missouri, Arkansas, maybe central Texas, and there is just a different density in terms of CF centers compared to the West. So I've always been told that Boise, our CF center, is the most remote CF center in the country, most geographically isolated. As I look at this map, I wonder if it's really Montana, it might be New Mexico, but we're up there. And then in terms of geographic isolation, there's a few other things that I would point out here. One is that we're not just isolated, but Idaho actually it ranks 49th in the US in terms of primary care providers per capita. We rank 52nd in the US. You wonder how we get to 52 in a second, I'll tell you. But we rank 52nd in the US in terms of pediatricians per 100,000 kids because we're behind Puerto Rico and DC. And it doesn't get better on the next states because Nevada's 49th and Wyoming's 48th. So this whole region has major access challenges, not only to a CF center, but to even collaboration sometimes with a primary care provider. And then to add to that, in the entire history of the state of Idaho, founded in, I think, 1863, we have a grand total in the history of one pediatric pulmonologist who arrived in 2012. Yes. So there really are major access issues here, and I'll share more in just a second. So what does this look like for our patients? Well, more than 1 in 4 of our patients drive over an hour to get to us for CF care. 1 in 8, it's over a 3-hour drive. And about 1 in 20, it's over a 5-hour drive to get to us. And each of these little orange dots that you're seeing here are some places where patients live. So the distance isn't just horizontal, it's also vertical. There's mountain passes and windy roads to get around these ridges. So this little dot here looks like it should be just an hour from Boise, when in fact it's a 3.5-hour drive. So it is really a challenge. Other challenges that we have include, just coordinating care in these rural areas. So as simple as before they even start coming for CF care, just the diagnosis of CF care, for care and newborn screening is a challenge. We live in a semi-paranoid state, the state of Idaho. So there's denial of science sometimes. There is refusal to believe that a newborn screen needs to be done, sometimes by patients, sometimes by physicians. But even getting the newborn screen done is a major challenge because of how far it is. So if I go back to this slide here, so last week, literally the day after our CF accreditation site visit, our sweat chloride machine went down, the chloridometer. When that happens, it was only down for 24 hours, but we didn't know how long it would be down for. It's a 7-hour drive, 6-hour drive to get to the next closest place to get a sweat chloride done. That's a major, major issue. The other thing that we run into because it's so far is we've had rural hospitals stand up their own non-CFF certified sweat labs and try to do sweat testing. And we've had to multiple times have cease and desist conversations with them because of just how untrustworthy they were. And then, of course, there's issues around clinic visits, access challenges because of roads. Virtual visits definitely have helped us in terms of some of these challenges. Because of the distance, we have difficulties referring people for such things as research studies that we may not be participating in. They may come and see us with a 6-hour drive and not be able to coordinate their endocrinology or GI consult at the same time. That's a major challenge. And hospital admissions, normally, for someone that lives in Boise, it's easy. For someone that lives across the state, it's much harder to coordinate and manage. And of course, all of us have our different challenges in our geographic area, but living in the rural West, there's a lot of farm dirt and dust exposure, which creates some different challenges. Stephen was talking about some of the particulate stuff that plays a role. Smoke and wildfire exposure. Smoke exposure in our valleys and in the West is an annual thing. Unfortunately, this year, many of you who it's not an annual thing had your experience with it, but it's an annual phenomenon for us. So enough about background. I spent, 7 minutes talking about background, just trying to lay out how things are so different. What about the evidence? What evidence is there about the effect of being, far from your CF center, living in a rural setting that might affect outcomes for CF patients? So I was invited to present my research related to this, specifically rural residents' outcomes and access in CF. The problem was I don't do that research. So I spoke with our organizers here, and after doing a PubMed search, trying to find someone who might be a better speaker on this topic, I quickly realized that maybe the best approach would be for me to kind of review the evidence, try and pull what little there is together. And so that's what we ended up doing. And I will tell you, and I apologize. But the one thing that I will tell you for anyone out here who is interested in epidemiological research, outcomes-based research. As you'll see in just a second, this is an area just absolutely ripe for study. There's tons of evidence available. We have so much information in our patient registry. This is really an opportunity. So the first thing that I did, I put in here PubMed search, but this is PubMed, Ovid, a variety of other ways to try and find things within the literature. I use the search terms cystic fibrosis and rural. And I found a grand total of 0 outcomes studies. And I found 2 relevant access studies. And they were both about telehealth. One was from Western Australia. And it did note that with telehealth, that it was very well received. It increased adherence in terms of IV antibiotic days, and there was an improvement in rural-based patients in terms of CFQR data. And then there was another one around telehealth that basically said that there was insufficient evidence to conclude the benefits of telehealth in CF, but it was a promising area for future investigation. That article was written in 2011. They had no idea the future investigation coming 10 years later. So I tried something else, and I said, what about cystic fibrosis and either center distance or clinic distance? And there was one article that came up. It was written by the gentleman to my left. And it's all we could come. This is the only outcome article, in fact, that I could find even directly related to this. It was a CF patient registry-based study that caught about 20,000 patients and associated zip code distance with longitudinal variation in patients' lung function over time. And basically what they found was that distance where the patient lived from the center was not associated with lung function among patients who stayed in the same place. But during that time frame, for those who moved, for patients who actually moved, older patients that moved further from their care center somehow developed better lung function, and young adults who moved further from their center developed worse lung function, but statistically it was significant, and it just, again, brings up more questions for, is that reproducible, what would be the cause of that, et cetera. So what about cystic fibrosis and remote? Tons of articles now about telehealth and how to mitigate the distance from the CF center, but nothing truly in terms of access and 0 studies on outcomes. So really, that is the evidence I was able to find. There is not more evidence out there. I will tell you, if we have time at the end and if someone wants to hear a crazy story, I ended up trying to find more evidence just using Google. Finally, I was like, I'm going to try AI and see if it uncovers something I went down this crazy misadventure rabbit hole on AI trying to find evidence that was purported there that wasn't. And I'll again, if you want to hear more about misadventures in AI, let me know at the end. So, one of the things that I decided to do, since I don't have great published evidence on differential outcomes and access for patients that live far from CF centers or rurally, is I said, let's look at our outcome data. Let's look at the patient registry data that we get. So how do we do as a CF center in terms of getting patients seen? And we actually end up doing pretty well, although that would be non-intuitive. This graph is the one that shows patients with 4 clinic or telehealth visits, 4 cultures, and 2 PFTs during the year of 2022. And everybody had a pretty significant dip in 2020, but we've remained at or above median, which is surprising for how far our patients have to come. We do use telehealth some. We don't use it a ton. And the way that we approach telehealth in our center is that we offer patients for their quarterly visits, basically they can be seen virtually once every other visit. So we want to see them at least every 6 months, but in the intervening 3 months, we're willing to see them by telehealth. They have to be 2+ years of age. We don't want to see babies because we want to be able to measure them and make sure they're growing well. We ask for them to use their home spirometer and have that information available, use a pulse ox, weigh and measure themselves, check their pulse, et cetera, so that we have that information. And we actually request them to drop off a sputum sample, if possible, to a system lab or a lab nearby so that we have that sample also and are not going so long between having microbiology samples. If a patient is sick, we prefer to see them in person. Again, when they live 7 hours away, sometimes that's not possible. So we'll do what we need to do, but we would prefer to see them in person. Another interesting outcome in the Mountain West, which has a lot of rural and distant patients, is this. So this graph is actually our graph, and then I superimposed red lines for the 7 other pediatric CF centers in the Intermountain West for median BMI 2 to 19 years of age. And when you look at this initially, it's like, wow, we stink. And by the way, our center is the furthest right. We're the stinkiest. We have what initially, at first perception looks like as a group, really big challenges. And historically, we've discussed this for years in our Mountain West CF Consortium. We have big challenges in terms of getting our kids to put on weight and grow. And we don't know why. It's universal. It's every year. We don't know if this is an access issue. Is it because it's so dry and it's humidity and sweat and salt loss? Is it altitude? Is it that we have that outdoors lifestyle, higher exertion piece? Is it diet? So we're really not sure about this. Yet, one of the things we've heard in this conference and here every year at conference is the tie between nutritional outcomes in kids and pulmonary FEV1 outcomes in kids. For these very same centers, these are our pulmonary outcomes. They're totally not tied together. 6 of the 8 centers are above the median in terms of pulmonary outcomes. And it's kind of hard to understand how that works and maybe what's different in our dynamic. Again, an amazing opportunity for research that we've talked about for years in the Mountain West and really haven't been able to pull off yet. So, conclusions from this talk. I'm sorry I don't have more evidence-based information to share with you. I was chatting with someone yesterday about disparities research, and I was telling him about my talk, and he said, wow, you should say that there's a disparity in disparities research, and it's true in terms of this area. So my conclusions are CF care centers in the Mountain West do contend with some very different dynamics and challenges. There is remarkably little published research about all of this. There is clear experience that rural and or distant location does affect patient ease of access, but not necessarily their patient visits or adherence. It's unclear if there are any meaningful differential outcomes between patients who live near their urban CF center and those who live far away. And finally, lots of opportunity for research. The one last thing that I forgot to mention at the beginning that I'll conclude with is, so going back to that definition of 50,000 people or less in the metro area, Idaho is the 14th largest state in the U.S. 50,000 would become our 6th biggest city, just to give you an idea of what the geography is like. So I'll stop there. I'm happy to take questions. Thank you very much.
Thank you so much. This was a wonderful talk, and I want to share something with you. So when we were given the task of inviting speakers for the symposium, one of the objectives was to look at existing literature and evidence for how rural communities are doing. And I did the same PubMed research, and I ended up with the same conclusion. There is no data, no evidence. So your name came up as an expert in rural science.
Well, thank you.
Hi, Bob Sun from Boston Children's, but this is close to my heart because I've worked as a general pediatrician in Pocatello.
All right.
Definitely firsthand also experienced some of these access. I have 2 questions that are different aspects of the care model. One is, how does your center engage general pediatricians and primary care physicians generally I think something I experienced being on the other side was feeling that for various children with chronic diseases, that we felt that it was hard to then hear back from the specialty center what was going on and stay updated when, as you say, if they live 6 or 7 hours away, then they're coming to the general pediatric clinic for a sick visit as the first assessment. And my second question is around care models in other settings. What can we learn from, for instance, congenital heart disease that also deals with very remote centers, very remote from their primary surgical center, for instance?
Yeah, no, thank you for your questions. The second question, I would say we can and should learn everything possible from those. There's for sure opportunities. And for your first question around care model and interaction with primary care pediatricians, family physicians, our center has a really unique care model. As I said, we founded our CF center 23 years ago. We didn't have our first pediatric pulmonologist until 11 years ago. I'm a general pediatrician. We have a family physician that is part of our CF clinic team. We have a peds GI doc, and now we have a one, soon to be two peds pulmonologist and some adult pulmonologists, et cetera. I would be a very, there's not enough pediatric pulmonologists out there, is the bottom line. And there's not enough in programs. Programs aren't filling. I actually have been advocating that we should be thinking about a PACE-like grant to train general pediatricians to become CF physicians and increase access that way. And regarding interactions with primary care providers, yes, we communicate with them all the time. They are our eyes, our ears. They are the care providers for these patients, and they can help us save the patient and the family many hours of driving. So we are, the further a patient lives away, if anything, the more proactive we are with those communications. It's incredibly important.
Hi, I'm Shipra. I'm one of the second-year pulmonary fellows at Cincinnati Children's, and I was just curious sort of how you guys manage your pulmonary exacerbations. Like, is it sort of admitting to the closest hospital and having communications with them, or does everybody have to come to Boise? And also, I know the CF Foundation is sort of shifting towards, like, is home IV antibiotics, equivalent to IV or inpatient, and is that even feasible? Like, does home healthcare reach all of these areas, or does that exist? Infrastructure exist?
Yeah, this reminds me when we had our very first CF Foundation site visit, and I think it was in like 2002, 2003. And we were joking around, did they think that our streets would be paved, that we would have 24 hours electricity, things like that. And we actually, in Boise, Boise's grown a ton, but even we've had a children's hospital there since I moved there 25 years ago. It's a very sophisticated children's hospital with virtually every subspecialty now represented. What we do for exacerbations is we admit to our children's hospital, we manage them. We are not yet at the place that we're doing home IV antibiotics right away, but we'll admit and then discharge after a little bit of time once we see that they're improving. It's going to be interesting to see what the evidence and new models suggest we do and how we change that. And we do have easy access for the entire time we've been in Boise. We have super easy access to home health, managing home IV antibiotics. That in some ways is actually easier in a smaller community that has sophisticated resources and such. So.
Well, excellent presentation. My name is Liz Cromwell. I work for CFF on the patient registry research portfolio. And one of the things that people ask for all the time is distance to their care center. And that on the face of it seems very intuitive, but after hearing your talk, I really think it's the population density per se that might be a good proxy for this ecosystem that people live in. And I'm wondering how much of the, we have so many patients on the eastern half of the country that their experience just isn't generalizable to what you're describing in the West. So I'm wondering if you had a wish list of variables that would be better than just as the crow flies, what would those be?
Yeah, that's a good question. I think, so it is population density, and yet it's also this weird geography. So our catchment area, our medical catchment area in our town that Boise proper is about 350,000. The Valley is at about 600,000. But our children's hospital is the most isolated children's hospital in the lower 48 with a catchment population of just under 2 million. So functionally, people drive further, but has a population of a pretty good-sized city. So I think drive time is probably a better measure than as the crow flies, for sure. You can't drive straight over the peak of a mountain or through a big lake. You can't. So I think that that's an important measure. And there, I think, has to be a factor of seasonality in it, too, because a drive that's 3 hours during the summer may be impassable, or a 6-hour drive during the winter. So, and those are factors that do not get taken into account, especially in a state where seasonality is actually 5 months of the year in certain places, certain parts.
I just have a comment. I'm a child life specialist, and I'm wondering if part of maybe your great outcomes and certain things that you guys are doing is because since you are the only place, do all those families feel this more intense tie to you emotionally, socially? They see you as this support that out in the middle of nowhere versus in these big cities or big areas where they could drive an hour in any direction, hit a different CF center. Maybe there's a different level of emotional connection.
I think there is something to be said about that. I think you're correct on that count. I think that the other thing I would have to credit is we really, truly have an unbelievably amazing team that our patients feel very attached to, very bonded to, very appreciative of. So I think that this could also very easily, in this degree of isolation, go south quickly. So,
fitting into that question, I'm also wondering about the level of activity of these children that you're taking care of.
Yeah, no, for sure. Our patients are very, very active. Some live on farms and are participating in work there. Most are playing sports of some sort. They're camping, backpacking. It's just a different lifestyle. And that's why we've sat back and said, well, maybe, we're at the tail end of that BMI curve, but maybe that's appropriate. And even so, especially these days, BMI, our being at the tail end means our BMI is at the 45th percentile median, which is almost normal. And I'm not sure that we want to be at the median, which is now 62nd percentile. But it's one of those questions.
2 more questions, and then we'll invite the next speaker.
Yes. So just knowing that you were talking in the beginning around the general distrust that exists in your region around professionals and medical advice and or just care, how does your team overcome that when a patient is originally diagnosed or when you're making care decisions together with the family? How does your team engage them and build that relationship so that you have that trust?
Yeah, it's a challenge that we face with CF frequently and that I face every day when I'm wearing my general pediatrician hat around vaccines and other such things. And the real answer is patience and having the conversation. And the thing that I've learned over time is when I'm starting to feel, admittedly, heart rate picking up, a little bit of frustration, what I consciously do is I put on my curious hat. And what I mean by that is if you start asking them, oh, why do you feel that way? Where have you heard that? Tell me more about that. And you start digging, not only does it build the relationship, but all of a sudden they get to a point where they're like, I don't know, or I'm not sure. And then you're at a point where you can say, well, let's talk about that. And I'd like you to think about it. We don't have to change our mind today. This isn't me trying to twist your arm, but you have to look at it as a series of conversations with patients and relationship building, because if you nuke the bridge, they're never coming back, but you can build that bridge.
Hi, I found this really fascinating. I am a CF parent in the Intermountain West. We go to Primary Children's Hospital. And I wanted to echo what you said. We are incredibly attached to our teams. We are in a much bigger area in Salt Lake City than in Boise and have other pediatric pulmonologists who still don't understand CF. And so if we're getting admitted and don't have someone from our team, we feel at sea. And so they've really worked to create kind of this, like, it's okay, they can take care of you. But we, just echoing what you said, incredibly attached to our teams and want to see nobody else.
Thank you so much.
I just want to make one quick comment about the analysis that you mentioned that we did. So first of all, not so much that moving further away makes you healthier. It's really that people who are healthier probably are comfortable moving further away, and people who are less healthy move a little bit closer. And then again, we were using the registry, which is zip code based for location, and I can imagine that there's maybe 2 zip codes in Idaho. Or something. So I mean, it just echoes the problem with trying to use the registry sometimes for estimating something like distance from the center.
Yeah, we do have the largest county in the U.S., and it's bigger than 4 states.
Our next speaker is Gabriella Oates. Gabriella is Assistant Professor of Medicine at the University of Alabama at Birmingham and scientist at the UAB Cystic Fibrosis Research Center, the UAB Center for Outcomes and Effectiveness Research and Education, the UAB Minority Health and Health Equity Research Center, and the UAB Center for Clinical and Translational Sciences, and that's all I have to say. You can, again, look at her biography in more detail online here, but we welcome her talk.
I can start it. Okay. Thank you. Nothing to the... Oh. What are we doing here? Okay. Sorry about that. I'm actually very glad I'm coming after Dr. Brown. So many thoughts. I totally feel what you're saying about not finding the evidence, because the gentleman to my right and I were doing a review paper last year and encountered the exact same problem when it comes to rural cystic fibrosis outcomes. And although you missed one study from Iran, in addition to the Australia study. But the reason I really am happy I'm coming after you is because in the 2018 paper that you cited about distance, there was a bullet point at the end, is that it's not as much the distance as it is the socioeconomic status. Because if you can afford it, if you had a private jet, it doesn't really matter how far you lived. And if you had nothing, even 5 miles are a lot to walk. So that's where my talk comes in. We're going to talk about things that we have a lot more evidence about, luckily for me. And it's how those socioeconomic factors come into the health outcomes in CF. So we're going to talk a little bit about the evidence, or the what. Then we're going to look a little bit about into the mechanisms. So how is this working? And then talk about strategies, or what can we do about this. So let's look at the evidence. Although cystic fibrosis is a disease associated with mutations in a single gene, there is a huge variation in disease progression and outcomes, including lung function, exacerbations, nutritional status, et cetera, even among individuals with identical CFTR genotypes. And those variations are not random. There is a very clear pattern, for example, by socioeconomic status, which we would assess with indicators such as income, or education, occupation, or health insurance type. So we want to look into some of this evidence today. If you look at children and adults with cystic fibrosis living in low-income versus high-income areas, you will see up to 10% lower lung function, twice or more than twice the odds of bacterial infections such as chronic Pseudomonas and MRSA, and 44% higher mortality risk. And what's interestingly is that these associations exist not just at those extremes of income distribution, very poor, very wealthy. Our prior work has shown a stepwise gradient, like dose-response association between income and lung function in children with cystic fibrosis in the United States, even after adjusting for all other demographic and majority of clinical covariates. So that for every $10,000 increase in annual household income in the United States, you have a proportionate 0.2 increase in FEV1. And what that means is that at the end of the day, a difference of $50,000 in annual income buys you a 1% higher lung function in children, which is quite a lot. So we see similar disparities by educational status, another measure of socioeconomic status. If you look at disparities in lung function by education, using either CF Foundation patient registry data or data from the EPIC study, you see 4 to 5% lower FEV1s in children at age 6 and through age 18. And what's alarming is that you actually see these great disparities in lung function in infants as young as 12 months of age after being diagnosed with CF through newborn screening. And these data are not exclusive to the United States. For example, an analysis of the Danish CF patient registry shows a 0.5% more annual decline in FEV1 in children from disadvantaged versus advantaged families. And over the course of time, this gap grows to 4% difference in FEV1 by age 17. So this is a European country with nationalized healthcare, if I may call it that. Similarly, in adolescents and young adults with cystic fibrosis, higher health literacy, which is an aspect of higher educational attainment, is associated with fewer exacerbations and better quality of life. So we covered income and education. Now let's look at disparities by occupation. The study from England and Wales, done quite a while ago, reports 2.5 times higher odds of dying above the median age of death from CF for people with CF who work in manual versus non-manual occupation. So occupation clearly is a source of the disparities. And we know that CF disease is known to limit one's occupational opportunities and functioning sort of across the board, but deprivation, living in poverty, actually amplifies the effect of CF disease on employment and is an independent risk factor for unemployment. So finally, we're going to look at another indicator of socioeconomic status, particularly in this country, which is health insurance. So when you look at differences in those outcomes by health insurance type, compared to individuals with exclusively private insurance, you see that those who are publicly insured have 9% lower lung function, 6.6% lower lung function at age 6, and 1% more annual decline in FEV1 during the transition period from adolescence to adulthood, as well as almost 4 times higher adjusted risk of death based on insurance alone. So now that we have done this sort of overview of existing differences or disparities by socioeconomic status, we really want to look under the hood and see, well, why? Like, how does this work? And that's important because it will tell us if you just give people, put money in their pocket, would that do anything or not? How does this thing operate? So those disparities that we talk about, the socioeconomic factors have multiple direct, indirect effects, as well as effects that result from interactions with biological and behavioral factors. And we're going to unpack this a little bit. On the extreme left, you see those upstream factors that we call structural determinants. So these are our larger economic and political systems, our governance, our economic policies, our social policies, as well as societal values. For example, discrimination or stigmatization. So this large context really shapes the stratification of our society by social class, by race or ethnicity, and shapes those environmental exposures that Stephen talked about in the first talk, our physical and social environments, our health system access, as we just heard from Dr. Brown, and this midstream conditions in which people live, we tend to call social determinants of health. But they also generate a lot of other determinants a little further downstream, those psychosocial determinants that my colleague to the left is so interested in. For example, family functioning, social support, the ability of our more disadvantaged patients to self-advocate, self-efficacy, coping mechanisms. This is all on the causal chain. And really together, those upstream, midstream, and downstream determinants determine people's exposure to stress, the stressors that they have to endure in their daily lives. And typically, those chronic toxic stressors are more in disadvantaged, lower socioeconomic status patients. They generate a whole cascade of biological processes, such as inflammation, immune response. They change the microbiome, as well as behavioral processes. They affect sleep, substance use, diet, and physical activity, and really interact with the biological factors, the CFTR mutations and modifier genes, and in their totality, affect those CF outcomes we are looking at. So it's not, we cannot really simplify this and say, well, it's just income and education and health insurance. There is an entire process behind it, and we need to be very careful about like sort of being very reductionist and oversimplify this process. So those social determinants of health affect everybody. They're neutral. They can either improve health or hinder or impact adversely health, and in their adverse manifestations, we call them social risk factors. And we can screen for those social risk factors in clinical settings and address those unmet needs that people choose to disclose to us. So what are the social risk factors for the disparities in CF outcomes that we just talked about? Now, this graph groups them into 5 buckets or domains that Healthy People 2030 chose to delineate: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment that we heard about, and social and community context. And you will see that there are a range of social risk factors that affect everyone, including people with CF. And these are on top in purple. But in addition to that, there is a host of social risk factors that are specific to people with CF, and they come on top of everything else. And that's why you will see those great fluctuations in CF outcomes among people with CF that are typically more extreme than in the general population. So, for example, in addition to the typical risk factors for economic stability, such as unemployment, you look at people with CFO, they have limited employment opportunities. They need more time off work, much higher cost of CF care. And as you move down those domains, you will see other examples of risk factors typical for cystic fibrosis. So what is the prevalence of those risks in the CF community? A good paper published earlier this year in JCF reported that among the sample that was investigated, 64% of people with CF report experiencing financial burden. This is what is like almost 2/3. 55% are in debt, financial debt. 33% experience food insecurity, 26% housing insecurity. And when you look at needs closely associated with CF care, you will see 24%, a quarter, reporting unmet prescription needs. And 10 and 12% report delaying or skipping or shortening hospitalization or CF care center visit due to cost. And remarkably, a couple of years ago, analysis of calls to the CF Compass, which helps individuals with various issues, 17% of the calls were about unmet needs. And half of those callers have two or more such needs. So it's not just one thing, it's usually a host of things. So our own research in the Pediatric CF Center at UAB showed something very similar. When we surveyed everyone at the center, the people who had needs had almost 3 needs at the mean, and then up to 8. And the needs of healthy food was reported by 87% of our population. Having food is one thing, having healthy food is an entirely different thing. 32% reported financial insecurity, concerns about health insurance, etc. What's really important, I talked about stress. The associated stress with those needs is high. It's above 3 points on the 1 to 5 point Likert scale, particularly stress associated with housing insecurity, financial insecurity, and health insurance, and has a profound health impact. So after accounting for other demographic and household characteristics, the unmet needs, particularly the health insurance concerns, were associated with 12% lower FEV1 among children, and almost 6 times the odds of multiple hospitalizations alone. So this is really serious. Keeping in mind, for example, food, that food insecurity is 2.5 times more prevalent among people with CF than the general population due to increased caloric needs and limited occupational choices and employment that actually affect people's earning potential. We see that residents in the food desert, so when you do not have good access to food, in children with CF is associated with 1 times higher odds of being underweight and 5 points lower BMI percentile in children. This is a lot. In adults, 1.5 times higher odds of being underweight. In addition to these very quantifiable burdens, we tend to overlook the invisible burdens and consequences of food insecurity. We did interviews with 26 individuals with cystic fibrosis across the country who live with food insecurity. They do not have consistent access to food. And these are, I'd like to highlight 3 things they said. The first one, who is a parent with CF to a child with CF, said, what you don't see is mom returning all these bottles just to afford that $1 box of noodles. And a patient with CF said, I eat chocolate milk for dinner because we just have nothing in our fridge. And finally, another patient with CF said, it's hard to gain weight when you're having to worry about making your food last to the end of the month. So food insecurity is one mechanism through which those socioeconomic conditions impact health outcomes. But as indicated prior by Stephen and others, housing and living conditions is another mechanism. Lower socioeconomic status, usually associated with worse living conditions, for example, molds. And molds are associated with ABP and CF bronchiectasis, as well as indoor air pollution, which is associated with 0.5% more annual decrease in FEV1. Another favorite topic of mine, tobacco smoke exposure. 1/3 of our children are exposed, either second or third hand, but they're not randomly exposed. Look at that. The exposure is 2.5 times greater in children who live in households with annual income less than $60,000. So Also, 2.3 times higher for children who have non-college educated parents. So very clear pattern of social stratification. Our disadvantaged children have worse exposures and great respiratory and nutritional adverse consequences. This exposure leads to 5% lower lung function at age 6 through 18. Removing the exposure really corrects that. As we have shown in our prior work, improving exacerbations, lung function, BMI percentile. But what is most alarming is that this exposure, which is most prevalent in our disadvantaged children, impairs the efficacy of CFTR modulators, as our bulk body of work has shown so far with ivacaftor, with tezacaftor, ivacaftor, and most recently with Trikafta. We have a poster on that. So even minimal levels of exposure lead to 1.4% less improvement in lung function among adults. And this number is wrong here. It's 43% higher odds of exacerbations among children. So what's happening? Our disadvantaged people with CF, they take Trikafta, they experience all of the adverse side effects and very little of the benefits. So what can we do about this? Well, I would start with this, that policy strategies and system changes and community-level approaches are more successful than individual patient-to-patient level approaches. And I would really like us as a community to focus on changing of policies. So looking back at those risk factors, so in terms of economic stability, what can we do to make changes for individuals with CF? Well, we can advocate for better food assistance programs. They're abysmal, for example. For a better supplemental income and care and rehabilitation policies. Looking at education, we can advocate for better educational support program and schooling accommodations. Looking at healthcare access and quality, medical nutritional assistance, there's just so much room for improvement right there. Access to modulators, newborn screening, etc. Neighborhood and built environments, we can advocate for clean indoor air policies. It's really important for people with CF, as we saw in the first talk. Or in terms of social and community context, disability protections. In clinical settings, we can screen for risk factors and assist with unmet needs. We can screen for and address smoke exposure. We can ensure consistency of care and really programs to improve self-efficacy and people's ability for self-management. Importantly, something that I believe is CF Foundation is looking into, funding models that account for patient disadvantage. So in summary, those contributors to the disparity in CF outcomes exist across multiple domains. They're multi-level, the mechanisms are complex, so our response, our strategies need to be multi-level as well, with those policy and system and community approaches being most effective. And finally, I am going to ask, why should we care? I mean, really, why should we care? Well, health disparities are costly, not just for the people who experience them, for everyone. It's a burden for healthcare systems and providers, for the society, because they get distributed, those excessive costs get distributed across society. So do not believe that just because you can afford it, you're not affected. They really cancel out great progress in medical advancements, such as CFTR modulator therapies and other anti-infective therapies. But finally, it's the human cost. And to me, that's the most important. And this is my friend, Georgia Brown. She's a 52-year-old person with CF. She's extremely smart and talented and witty and funny. And she has lived on disability and in poverty for most of her life. And Georgia has this message for us today. That's what she wanted me to tell you all. We are grateful for the tomorrows, we are. But many of us are struggling just to get through today. And I'll end here.
Thank you. Any questions? Oh, here's a question online here. Is there the opportunity for local hospitals to perform? Oh, this is actually for a previous speaker. We'll hold off on that question. I have one or two comments, and hopefully that Gabriella can comment on, or there'll be questions. But I think one of the emphasis that I just want to repeat is that we can talk about categorical poor versus not poor, but I think it's really important to recognize that there's a spectrum here. And so really when you talk about the impact of these social determinants of health, they really impact on, if not everybody, again, adverse determinants clearly impact on a significant proportion of our patients. So this is really something that we really need to be aware of.
I'm Mary Dwight with the CF Foundation. Thanks for a truly excellent symposium thus far. And Dr. Oates, thanks for a fantastic presentation. I want to particularly applaud your slide with great bias on a call for policy advocacy. And I want to make sure that everyone knows that almost everything that Dr. Oates put on her slide of what we should advocate for is absolutely on the agenda of the CF Foundation, with a request to the audience that if you are inspired and empowered to ensure that you are part of the CF Foundation's advocacy efforts. I particularly want to call your attention to Dr. Oates' plug on food security programs. We are about to get eviscerated on those. This House has proposals to drastically cut what is already underfunded. We will be advocating for this vigorously, and I encourage you all to do the same.
Thank you, Mary.
Hi, I'm Priscilla. I'm a pediatric resident at Boston Children's. Wonderful talk and really near, close to my heart in terms of social determinants of health. I was just wondering if you have a little bit more data as to how these outcomes compare across race and ethnicity.
In CF or in general?
Sorry?
In cystic fibrosis.
Yes, in cystic fibrosis, yeah, especially around the slide where you highlighted kind of the stress around like security, housing insecurity, and all those other outcomes.
So I'll be blunt, we do not have much data in cystic fibrosis. We're doing a poor job. We are working toward this. We can, at this point of time, we can definitely extrapolate because we do see those patterns of disparities by income, education, etc., maintain within racial groups. So whether you're Black or Asian or white or Hispanic or not, wealth is wealth and poverty is poverty. So we do see those stepwise socioeconomic gradients within racial groups. But even at the same level of income and education, non-white groups perform worse. And this is an example of the sort of the systemic discrimination, the social structures that generate these things. So I don't know if my colleague Liz Baker wants to comment on this, but you're shining light to we have not done a good job yet in explaining those disparities in cystic fibrosis. I don't know what else more to say other than we just need to do the work. Anybody else wants to add to that? I don't know.
That we are about to run in early next year. We'll be rerunning the health insurance study, which will be an expanded version of some of the data that Dr. Oates presented today that will take a deeper, more expansive dive on many of these social determinants. So please stay tuned to that in your center. It should be coming out, I should know this, I want to say spring.
Yeah. Oh, can I add one more question, Priscilla? Thing to Priscilla's question, actually. What's interesting, and we see across disease states, I can't imagine CF will be different, is that individuals from minority backgrounds with higher income and higher education actually experience worse outcomes through greater exposure to discrimination at the workplace or elsewhere, because more contact points to experience discrimination, and much more a higher level of stress hormones. So the stress process definitely is part of this cascade that we just need to unpack.
I want to make a quick comment. So we are collecting this data in the registry. However, the registry data is not very accurate. So when you go back to your centers, please ask your patients questions about race and ethnicity and update your poor CF data so that it more accurately reflects your patient populations. I think that's very important. So the future data can be more accurate on this patient group.
Okay, one last question.
Chris Landon Ventura, pediatric pulmonologist. Within our own clinic, through Healthy Analytics and Cerner, we can do Childhood Opportunity Index, Area Deprivation Index, and what we're hearing over and over again, and air quality and so forth, is that I'm hoping that the CF registry is going to start moving towards that kind of geographic information system where we can start to dissect these things out, or at least in the individual centers. That you can do that. Are you starting to do that in Alabama, or?
We're doing this in Alabama. Yeah, we're blue in the face doing it. We do it all the time. But is Liz Cromwell here?
Yeah, I think she left.
Yeah,
Yeah.
yes, there are conversations
her on the
about
spot.
this with the CF registry. Yeah, there are some issues, which is zip codes. We don't have addresses in the registry.
It seems like CF Foundation is working on updating the CF registry, and hopefully we will get more information in the future. But good point.
Yeah, thank you for this plug. I like it.
Okay, thank you.
I would like to invite our next speaker. Our next speaker is Kathy Mims. She is currently a program manager for the CFF-sponsored program CF Training Network Latin America and the International Mentoring Training Initiative based at UAB. She's a colleague of Dr. Oates. And she's going to talk about the International Mentoring Training Initiative.
And thank you very much for the invitation to share about our program. I will digress and tell you that I will not show you any statistical charts in this presentation, so just be prepared. So I'm going to share about the International Mentor Training Initiative that we began at UAB. And as soon as I figure out which one does the next slide, here we go. These are my disclosures. And I want to start off by saying that if you go to the CF Foundation website, what you will see as a quote there is people with CF are living longer, healthier lives than ever before. And this is true, right? And we can be very proud of that because of the work that the centers have done with support from the CF Foundation and quality improvement and the research. And now we can attribute a lot of that to modulators. But is it true across the globe? I don't think so, and I think we've heard evidence of that in the conference here so far. Jonathan Wu and his colleagues suggested, based on epidemiological data from several different sources, estimate that 162,000 some odd people have cystic fibrosis across the world. This may include some that are not yet diagnosed. We believe that less than half of these received standardized multidisciplinary care, and likely far less than 20%, we know, received triple combination therapy. Because of this, the survival gap for people with CF continues to widen between the U.S. and the lower and middle income countries. If you look at this chart, you can see and this is really based on CF patient registry data and also anecdotal reports from key opinion leaders that we have worked with in LMICs. There is not really great statistical data to know, but this is a very good estimate, we feel. And if you can notice the U.S. is the blue, and LMICs that we've worked with is the yellow, and clearly there's a great disparity there. So the key question is, can this poor trend be changed if many factors are at play? Many countries don't have access to traditional medications, let alone to modulators. There's often poor clinical awareness and poor diagnostic suspicion for CF. Poor care delivery by trained teams. And I'm not saying that teams and professionals are not trained. They are very well trained, and we have found that they are very smart. But the care delivery process, how the team works, is not necessarily the best. So the questions that we need to answer is do you think this is a problem? Yeah. We could say it's a problem, but it's not my problem. But we choose to say it's a problem, and we want to make a difference and make a change. So our journey started in 2014 when our team initiated a collaboration with one team from Santiago, Chile at Hospital San Borja that cared for 15 or so pediatric people with CF. We began working with them, mentoring them, training them on how to work together as a team, and talking about the CF guidelines and changing some things in that fashion. By 2017, we were working with mentoring 5 teams in Chile. We mentored them on evidence-based practice, multidisciplinary team function, QI methodology, and basically how to function better as a team. In 2018, with support from the CF Foundation, we formed the Cystic Fibrosis Training Network Latin America. And we also began to partner with teams from Argentina at that time. We partnered with Dr. Fidel Ruiz from Baylor, who began training teams in Mexico. He has one team in Mexico City and one in Monterrey. And this was the beginning, we feel like, of a sustainable program to be able to mentor trainees to improve the care that they're providing. The ultimate goal is for the teams in these countries to be able to become trainers of their local peers and therefore improve outcomes across the country. So what is the MT program? In 2022, we collaborated with the CF Foundation to develop a program to train U.S.-based teams on the methodology that we've been using over the last 8 years. We were able to obtain a grant for this and began working with some CF teams from the U.S. How did we do it? We sent out applications to the CF centers across the U.S., and we received 15 applications that were evaluated on merit of prior experiences with an LMIC, alignment with the goals of the CF Foundation's global initiative, their QI knowledge and implementation of QI, and also their commitment to the training program. 3 teams were chosen based on these qualifications, and our international team, which is, I'll show you a picture of at the end, provided them with training over 6 months. We had 2-hour Zoom sessions once a month, and at the end of each session, they had specific actions that they should take to prepare for the next session and to get them ready for training the LMIC that they had chosen to work with. The methods that we teach fall under these 4 categories. Number 1 is partnering with the team. So we feel it's very important to learn and understand the way that the team provides care in the LMIC center. We need to know, is there a team? Do they have all of the required disciplines that are needed to provide adequate care? And then how do they work? What are their patterns? What are their processes? What are the dynamics among that team? Are the disciplines empowered to use their expertise in the way that we use our expertise here in the U.S.? The second most important, we feel, is the bidirectional benchmarking visits. And what we do here is the LMIC team comes and spends 1 week with us at our CF center. During that very, very busy week, we have them attend clinic and observe our team in action. We have quite a few didactic sessions throughout the week, providing education on CF Foundation guidelines. We really focus on quality improvement, and by the end of the week, that team develops their next step. What are they going to do to begin their improvement journey? The third aspect is looking at leadership. In our experience, teams in Latin American countries are often primarily led by the physician. Everything is driven by the physician. They may not even have a full team, and everybody looks to the physician to make decisions, which is different from the way we often work here in the U.S. We work with them on how to manage up and how to manage out within their system. We know there are barriers that we cannot change. We don't provide them with things, but we teach them how to work within their system to be able to gain the resources that they need, and help them to communicate better with their management people. The final aspect, of course, and another most important one, is data management, teaching the importance of collecting data. Oftentimes, most countries we've worked with don't have a very adequate registry. It's not a functional registry where they can retrieve data about their patients from very easily. So we teach them the things that they need to collect, the minimal data that they need, and also teach them how to use that data for improvement. These are just a few of the activities that the U.S. teams who are training in the MT program will complete during the training. We ask them to learn a little bit more about the healthcare culture and what's happening in the country that they're going to work with. We ask them to begin to meet with their LMIC team and to begin to develop a 5P assessment, and that's learning about the patient population, the professionals they have, what processes, what patterns do they have, and what is their overall purpose? What do they want to accomplish by doing this? We ask them to go ahead and conduct an initial meeting with their LMIC team. Go ahead and begin to get to know them and begin to think about how they're going to move into the next step, which hopefully is to gain funds to begin their visits. And this is a sort of a busy organizational chart, but this sort of helps to display, I think, the work that we've done. We have worked with teams in Argentina and Chile, and there currently are two teams in Argentina who are beginning to work with 3 other teams locally. Baylor is continuing to work with Mexico. The 3 teams that have participated in the MT program are Boston Children's, Columbia, and Stanford. And Boston has a history with working with Jordan in some ways, and they will be furthering their work in Jordan. Columbia will be working with Ecuador, which they have already started, but all of these teams are now going to be working in the fashion that we have through the MT program. And then Stanford will be working with a team in Peru. Over the last year, we tried to figure out how many patients we might have actually been able to affect, and we come up with the estimate of more than 750 patients in the countries that we've worked with have been affected and impacted by having their team improve their quality improvement work. Hopefully with the MT program and more teams training, we'll be able to make this go even further. That's our goal. And this is my team. We did this all together. We couldn't do it alone. So I want to thank each and every one of them, and also thank Dr. Farrow and Namrata Patel from the foundation for their support.
in the interest of time, we're just going to move to the next speaker. The next speaker is Dr. Gökdemir. I don't know if I'm pronouncing that correctly. She's a professor of pediatric pulmonology in Marmara, Istanbul.
Thank you. First of all, I would like to thank the organization committee for their kind invitation. And I will briefly summarize the collaboration between Michigan and Marmara University. Sorry. I have no disclosure. And I would like to first start by giving some information about our center. Our center is located in Istanbul, and Istanbul is the biggest city on Altı with 16 million residents. And we are the largest CF center also in Turkey, and we currently follow up approximately 450 CF patients. And in our structure, we have enough number of attendings, but the other healthcare providers are inadequate. We have only 2 CF nurses, 1 dietitian, but we don't have a social worker or psychologist in our team. We first started to register our patient in ECFS patient register system in 2015 as a single center from Turkey. And Marmara Michigan collaboration, and we named it as MAMI, and I will a MAMI collaboration, and I will use this MAMI collaboration for the rest of my talk. And we did 5 in-person visits during this collaboration and many online meetings especially during the COVID pandemics. And the first exploratory visit was very important in 2018, and we presented the current status of CF patients at Marmara University. At that time, we had 279 CF patients, and only 14% of them were adults. We did joint meetings with the other departments, and problems in CF patient care and methods for solution were discussed in this mission. Also, Professor Samia Nasr gave a talk in our hospital about CF care, and at that time we had 2-room CF center, and it was insufficient for our CF patients, and infection control measures were not strictly applied in our center. And after that, we arranged a meeting with the hospital administrator, and this was a very fruitful meeting. And after this meeting, we convinced our administrator to have 2 more rooms for our center. And these are the pictures from the opening ceremony of our additional 2 rooms at March 2019. And after the MAMI collaboration, we started to follow better infection control policies. And the main problems of our center was the low BMI percentile and low FEV1 percentile compared to our European peers in every age group. So we decided to conduct 2 QI projects. One is about BMI increase, and the other is FEV1 increase. And this is the first paper from our collaboration that describes the structure and the QI projects. And this is our first QI project. It's about BMI, and we followed the quality improvement tools, and we implemented the Michigan University standardized nutritional algorithm to our patients, and we obtained a significant increase in BMI percentile after the first year of the project. And the patients get most benefit was the critically at risk and urgently at risk patients. And in terms of quality of life increased in 6 to 13 years old patients, also in adolescents with this project. And the other QI project was FEV1 project, and our aim was to improve FEV1 in patients with cystic fibrosis between 6 to 18 years old in Marmara University CF Center. And we did weekly case review of patients with FEV1 below 80 to develop individualized treatment plan for each patient, to find out the barriers to adherence that may result in low FEV1, to assess these barriers for each patient. And we created 2 fishbones. First fishbone was to detect the factors affecting the low FEV1, and second fishbone was created to find solutions to low FEV1. And we did many interventions to increase the lung function. I won't go in detail, but we did the interventions in terms of therapies and airway clearance methods, and also we did many educations to the patients and also to the parents. And at the end of the 1 year, the FEV1 increased significantly. 10.5% increase was obtained with this QI project, and at that time none of our patients were using modulators. This was only the result of this QI project, and we did here you see the other publications of this collaboration, and we did depression and anxiety screening in our patients, and these tools were used for the first time in Turkey. And we also gave education about nebulizer hygiene training, and we did pre and post test to evaluate the knowledge level, and the parents' knowledge level increased significantly, and these were also published. And during this project, we were invited to attend to the VIP F7 Quality Improvement Project, and we were very happy about that. And here you see the picture of one of our meetings, and we did weekly meetings with our coaches, Pam and Randy. And in this educational program, we decided to translate and adapt CF RISE to Turkish, because we had 88 adult CF patients at that time, but we didn't have a standardized transition program. And after translating this program, we started to use it in our patients, and we created 12 educational leaflets and did 4 webinars, including these 12 subjects, and we uploaded this to the website of the Turkish CF patient organization websites for all patients. And in 2022, we 5 healthcare providers attended North American Cystic Fibrosis Conference in Philadelphia, and we visited Michigan's University of Michigan CF Center for 5 days, and we did meetings with multidisciplinary adult and pediatric CF teams, and we worked on new QI projects and studies, and we presented the preliminary results of the CF RISE project in this conference, and we received our VIP F7 attendance certificate as well. And here in this Congress, we presented the 1-year results of CF RISE project with the poster number of 640. And in other 2 of our pediatric pulmonology fellows visited University of Michigan CF Center for 2 months, and they observed all the CF team during the CF outpatient and inpatient clinics. Last year in Mott Children's Hospital, we planned new studies about social determinants of health and also food insecurity in CF, and this was the first time, these were the first studies that were done in CF in Turkey, and food insecurity rate was obtained in almost half of our patients, and also 65% of our patients reported that they needed support in various sub areas. So we are looking for finding resources for these patients. And as a conclusion, what has been changed after MAMI project, we started to follow strict infectious control and segregation protocols, and we started doing pre and post-adult meetings, improved nutritional and chest physiotherapy management after QI projects, and we started to use standardized transition to adult care, and we started to include family organization representatives to CF meetings and studies, and increased this collaboration increased motivation of all CF team members in our center. And what are we expecting in the future? For sure, our first aim to increase the survival of CF patients in Turkey and in the region. And we would like to add social workers and psychologists to our team and continue QI projects. And we will collaborate with other centers in Turkey and in other parts of the world. So many thanks to CF Foundation and MECFA for their support. Thank you very much.
Thank you. That was really impressive work.
Thank you.
We have a few minutes left for questions for maybe all of our speakers.
Yeah, that would be great if you could all come here. I know Stephen had to go, and that's why he had just a little bit longer time for questions. If anyone has, Teresa.
Hi there, my name is Teresa Todd. I'm the program manager for the CF Learning Network. I really don't have so much as a question, but I just want to applaud the work that you've done. You clearly showed what can be possible by using quality improvement methods. Sorry, I'm a little nervous talking. You mentioned that you don't have modulators. The success that you showed was without modulators. And I think that's really critical for us to remember that looking at our systems, truly evaluating our systems and making small improvements can lead to a lot. So thank you very much.
Thank you very much.
So here's a question that we had previously from the online system. Is there the opportunity, is there the opportunity for local hospitals to perform sweat collection, but then send samples frozen to your center for analysis? So that's.
So I'm sorry.
So the question is there the opportunity for local hospitals to perform sweat collection, but then send samples frozen to your center for analysis?
So that is on the docket as our next QI project, actually. Remote collection, I think, is something that would help us tremendously. So St. Luke's Children's is part of a now, I think, 9-hospital network throughout the region. So we have good reach a little bit north and some to the east, a little bit to the west. So a lot of our population can drop off samples within one of the network hospitals and then have it shipped to our St. Luke's Children's site for processing. But for people that don't live near one of our network hospitals, we're trying to figure that out. So that is actually in progress now.
I have a question for both Dr. Goldmeier and for Kathy. So this is wonderful work, and I'm really, really happy to hear about it, what you do on the international arena. So do you have a care center network in Turkey? And have you looked at your registry entry for the European registry? And then for Kathy, the same question, like, is there, for the future, are there any plans of implementing this QI and teaching these teams to teach other teams in their country to implement the same QI? And, have you thought about what next?
Answer first.
Thank you. Now there is a national registry, but actually the national registries are for benchmarking, but in Turkey this has not been started yet. But I think we have to spread the QI project and all the tools that we learned from this collaboration. So we will work on that.
Yeah, so regarding the regional kind of network, the teams in Argentina are coming together. We have had several meetings of them, at the same time, and they're really working towards making a CF center network there. And the same in Chile. The pandemic kind of slowed that process down, but they are now back at work trying to pull together as far as a regional network. And then regarding their registries, they again, they're not very useful, but we are also piloting a REDCap registry that we developed at UAB with 2 of our Argentina teams, and they are using those routinely for patient care. They're able to pull patient reports and also see how their center is doing. So that's something that we plan to share with the other teams too.
If I can ask a follow-up question, and you may or may not know this, but is there interest in spreading the work that you're doing beyond Latin America? Again, I think that what we're beginning to understand is that, for example, Asia has a lot of patients that are currently undiagnosed, but maybe there'll be some increased awareness over the next few years. So I think the idea of helping to develop CF teams in other regions of the world is also important.
Yeah, and that's exactly what the MT program was intended for, to spread that improvement to other areas, because all 3 of the teams participating are, 2 are in Latin America, but different countries than we've been in, and then Jordan. So that's really the goal, is to just keep that spread, have them begin to their teams train teams, and hopefully it's going to grow tremendously.
So the question about registries is twofold. One is that globally we can learn more if we have more data in the registry. But the second is we know so little about the mutations in, like you said, in Asia, in Latin America. And I think we can learn so much more from gathering that information.
Absolutely. Yeah, and that's something that we hope to work on too, is having all of the patients' genetic information into this REDCap registry. So all of the teams that we work with currently have done that, and we hope to expand that so that we can see it further.
I think we're at time.
We are on time. We are on time. But if you have any other questions, last question.
Hi, good afternoon, everyone. So I have a question on the registries for Latin American countries and other countries around the world. It's a great work that you guys are doing with the MT program, but I'm wondering, what do you think would be the best way for these teams that sometimes they are reduced teams. Sometimes it's just a doctor and a nurse in a center, and collecting the data might become a burden to them. So what do you think it's the best way for them to be able to acquire local resources that would assist them in getting better data documented in these registries that they're building?
Yeah, that's been an issue too, and it's a very good question. And the way the registry is developed that we have put together, each discipline can actually enter the data that they collect based on the patient that they're seeing. So it's a shared effort. It's not just one person entering the data. We of course also work with them in reaching out to their local resources to try to maybe gain extra support for data entry. But the way it's shared right now, I think it's going very well. And some of the folks here might want to comment on that. I don't know, but we've got some of the data entry people here, Martine and Dr. Castaño as well. Noelia. They have been able to get their data entry down to about 12 minutes, I think it was, right? 12 minutes.
just to mention about the strategies for data entry, because, for example, in Turkey, we are not paid, and in some centers, only doctors are doing this and really have a burden. And also, we are talking about the harmonization of the data and global CF registry. So I think the solutions should be country-based, because in some countries, maybe governments can help. In some countries, maybe some resources like CF Foundation or ECFS can help, but just a little amount of money is important. For example, ECFS is now giving for 40 euros for each patient and not encounter based, but annual entry for it. So this can be a solution that we can discuss. But also when we talk about the global CF registry, maybe we need a very simple, not a complicated, not a very detailed one like US has. It will be enough to see the whole population with CF all around the world. And also with this chance, I would like to thank CF Foundation for supporting the decreasing the inequity to health, access to drugs and access to health care with the CF patients. And also you can see that from the presentation of Yasemin that really with a little support, everyone can create miracles like modulators, 10% increase in FEV1, and we were nearly crying when we entered the data. And also ECFS data controllers warned us, are you serious that you with the results, because you are not using modulators? And we just talk about this, and yeah, thank you very much.
Hector Gutierrez from University of Alabama, Birmingham, and we have been leading the CFTN and the MT. Question, expansion. This program is clearly replicable. We can find anywhere in the world teams who can develop the progress and show the progress that Marmara has done, or Argentina, Buenos Aires, etc. This is clearly doable. It's a question of, do we have enough people to do it? That's why the CF Foundation ask us to distill what we have learned for 8 years in training teams into a didactic program for high-performing teams in the U.S. to train others. So Carlos Meyer at Stanford took a team in Peru, etc., and Ahmed Ulur from Boston and a team in Jordan. That's one. Second, registry. Argentina has a registry. Many countries have a registry. It's not used much because it's a burden to enter the data. They need something like an app. How many of us have downloaded an app in our phone and never used it? If they use the registry, it has to be helpful for them. And that is the key change between having an LMIC using a registry. They are not using it for the population-based information. They are using it to manage their patients. And that has been what has been successful in them. They find a way, the time to do it into their daily routine. And their data is actually real time. We review it. The RedCap server at UAB can review the information from the pediatric center in Mendoza or the adult center in Mendoza in real time and offer for them information that they plan for the next visit. I cannot do that in the registry in Canada or in Europe. In the US, you have the CS Smart Report, but that's an exception. And that makes the difference for them. They need to develop tools that they can use. That's it.
Yeah, what I had in mind was training these teams in different countries so they can train other teams in their country. I think that would be a great way of spreading the QI knowledge, because I don't think there are enough high-performing QI teams in US to support all the teams out there. But great program. Thank you so much, everyone, for attending.
Thank you.
We really love that.